Services Finance and Policy Committee for Monday, September 23rd, 2019. And members, even though we are convening, the language we'll have before us will not be live, so not amendable. Senator Pratt has developed an insulin policy based on some principles we talked about, covering those who need it, not having the Department of Human Services responsible for the implementation of the program. And so we'll begin the process of vetting and challenging this language, making sure that it works for the stakeholders and those who are dependent on insulin. And so you have your agenda before you. We have, as of this point, we only have 2 public testifiers. And so if there are other members of the public who intend to come forward, I've asked that Senator Wicklund designate someone that she would like to have share their story, because she has been such an advocate in this area. With that, Senator Pratt, please proceed. Welcome.
Well, good morning, Chair Benson and committee. Thank you for having me today. Certainly the rising cost of insulin has been devastating to families and individuals in Minnesota that live with diabetes. During the budget session, insulin affordability dominated the debate in the early morning hours of May 25th. Both the House and the Senate rejected nearly identical amendments to implement emergency insulin bills, the only difference being the funding source. That weekend, I joined Senators Abler, along with Jensen, Housley, and Anderson, to say that the resolution in both chambers was disappointing. In that article, printed on May 29th, we stated, with Senator Abler's lead, we are committed to a real solution that will truly make a difference, rise above the political rhetoric, and actually get a program launched that will save lives. A bipartisan group of legislators then met to see if we could find a solution. That group broke up at the end of July at an impasse, and quite honestly, too soon in my opinion. It provided a general framework, but it still had 4 unresolved issues. There was no plan to help patients afford insulin after 90 days. We never agreed whether it was a temporary or permanent program. The implementation effort and timeline was too long and created a whole new bureaucracy. And the funding source was never really agreed to, although we did begin conversations around a shared cost model. No proposal was ever reviewed. I was out of town when that story broke in the news, and I spoke with Senators Abler, Jensen, Benson, and Miller during that time. We decided a stalemate was not sufficient and that we needed to think outside the box that we had created for ourselves. DHS became embroiled in controversy that led to resignations of staff and leadership, revelations the agency had misappropriated nearly $80 million, and more recently charges that's by state employees of retaliation if they reported waste, fraud, or abuse. It became clear to me very quickly that DHS needed to get its own house in order before taking on a new program like this. Following legislation passed last session, we saw major health insurers step up and cap co-payments at $25 for insulin. The changing landscape during that time changed the direction I took towards insulin affordability. Last week, we released the outline of a plan, and I appreciate Chair Benson for scheduling a hearing to accommodate my work also on the Jobs Committee. The plan is relatively simple in its concept. First and foremost, this plan provides resources for Minnesotans to get affordable insulin. We achieved this by establishing an insulin affordability program as a safety net for anyone below 400% of the poverty line. This equates to nearly $50,000 for an individual and over $100,000 for a family of 4. The patient goes to the MNsure website and applies for the insulin assistance program. MNsure has 5 days to verify the patient's eligibility and issue a patient number. The patient takes that application to their doctor to have their prescription information added, and then the form is sent to the appropriate manufacturer. The manufacturer then sends the insulin to the doctor's office for pickup, as they do with their own patient assistance programs. We expect that MNsure would also connect applicants who qualify for public insurance programs so that they can be enrolled and taken off the insulin assistance program. And because we're using existing infrastructure and distribution channels, I believe that we can get this program set up in 60 to 90 days. So here are a few key differences between the Senate plan and the House plan. The House plan only covers 90 days. And the question I've asked is what happens after day 91? Their plan kicks in when diabetic patients are in crisis. Our plan tries to catch patients before they're in crisis. This plan does not assume that there's not this plan doesn't assume that there's not a need for emergency insulin. And further discussion can and should continue. But we also should be able to agree that providing help to insulin-dependent Minnesotans before they feel the need to ration is a better approach. We worked through MNsure to get qualified uninsured applicants enrolled in an insurance plan. The House plan will take 9 to 12 months to implement. We think ours can be up and running in 60 to 90 days. Our solution has a sunset because we need to be accountable to a long-term comprehensive solution to insulin and other health medications. Our solution uses the existing supply chain, which should result in minimum disruption for doctors. And to quote Senator Jensen, this fortifies the relationship between the physician and the patient. This is a multi-pronged approach. After hearing some of the feedback and questions this weekend, let me just clarify that the intent is not to replace insurance, undo the impact of last session's legislation, or really undo any of the existing assistance programs. This program addresses the issue of insulin affordability and ensures a reliable source of insulin until an applicant can enroll in an affordable insurance plan. And we must still address details of how to protect against waste, fraud, and abuse. Madam Chair, that's my opening statement.
Okay, thank you. Members, let's proceed with our public testimony and, our listed testifiers. And after we hear some of those questions, I'll ask members to address Senator Pratt. Next on our list is Ms. Nicole Smith-Holt. Welcome.
Good morning, Madam Chair and committee members. My name is Nicole, and I'm here today to share a very painful and personal account of the death of my son, Alex Smith. In 2015, Alec was just turning 24 when he became very ill. He went to the doctor and was diagnosed with type 1 diabetes. This came as a surprise to our family. We have no family history of this, and he was always very healthy and active person. Alec handled his diabetes well. He adjusted his diet, he handled his daily regimen, and he took responsibility of his life and for his treatment. While still under my insurance, Alec would sometimes struggle with the affordability of his insulin and supplies. At the time, he was a server and a bartender, and during certain periods of time for business was slow, and he made less tips and would struggle to afford the bills and prescriptions at the same time. Even with insurance, his bills at the pharmacy would range between $200 and $300 a month. In May of 2017, Alec turned 26. On June 1st of 2017, Alec was no longer eligible to be covered under my health insurance. For months prior to this date, we searched online to figure out what his options would be, since his employer did not offer insurance. What we found was scary, to say the least. In 2016, in December of 2016, Alec was offered a promotion at work, and he was promoted to manager of the Anoka Khan's Mongolian barbecue restaurant with a salary of approximately $40,000 a year. Because of his salary and his family size of one, he was not eligible for state or federal subsidy for insurance. He did not qualify for patient assistance programs from the insulin manufacturers, and so he was left with two options: Number one, to pay an extremely high premium and deductible for a plan through the ACA marketplace. Or number two, go without insurance and pay out of pocket at the pharmacy and pray nothing major happened. Alec had plans to find a new job that did offer insurance, but as we all know, that can be difficult. Alec made a difficult decision to forego his insurance. His choice was number two. He could not wrap his head around paying $450 a month for insurance that would not kick in until he had spent $7,600 on medication and supplies. That is what his deductible would have been. That number is pretty scary. That was a lot of his income. Alec's first visit to the pharmacy in June without insurance was scary for him. I can only imagine what he felt like when he left that pharmacy without his essential medications that he needed to stay alive. Alec was told his bill for his insulin supplies were $1,300. From accounts of those closest to him, we have put together a timeline that is accurate as we can get without Alec here to verify the facts. On June 20th, Alec stopped by my home. He went with friends to Wisconsin for fireworks, and he visited with family and paid his car insurance. He looked well. I saw no signs of stress or distress. He informed me that he would be picking up his meds in the next day or two. On June 22nd, Alec went to the pharmacy, left without his life-saving medication. We believe he felt like he could stretch out his remaining insulin to last until payday on June 30th. From his bank account records, we could see that he had approximately $1,000 in the bank on that day. On June 24th, Alec was with his friends at a going-away party. Friends reported that he seemed fine, nothing out of the ordinary. On June 25th, Alec's girlfriend stopped by his apartment, and that evening they went to dinner. He wasn't feeling well. He complained of stomach pains, fatigue, sleepiness, and headache. He was not able to eat and just wanted to go home and go to bed. On June 26th, Alec was supposed to go to work. He called in and left a voice message for the restaurant that he was ill, and he was having difficulty breathing and had a severe headache. On June 27th, Alec's girlfriend had been trying to reach him with no success. She went to his apartment to find out why he was not responding to calls or texts. His car was in the parking lot. He did not answer his door. She could hear his phone ringing and got worried. She found an unlocked window and climbed in to find him down on his bedroom floor. Alec was pronounced dead on the scene. The official cause of death was diabetic ketoacidosis. The medical examiner believes that he had been gone for 18 to 24 hours when his body was found at 5 p.m. on June 27th. On July 5th of 2017, we had a funeral for my beloved 26-year-old son. That was the hardest day of our life. Diabetic ketoacidosis is one of the most serious complications of diabetes. Symptoms come on rapidly and can take you by surprise. Without treatment, you can go into diabetic coma and die. This happens when your blood sugars get too high and you do not have enough insulin in your body. Your body turns acidic and your organs shut down. Symptoms of DKA are abdominal pain, thirst, nausea, weakness, shortness of breath, vomiting, urination, and severe mental confusion. As you can see, these symptoms can appear as a virus or an ordinary illness. They come on quickly and can take you by surprise, and often when they progress, the mental confusion sets in and may hinder one from calling for help. We believe this is what Alec experienced. We believe with the mental confusion, he could not call for help and didn't realize that he even needed the help. I can tell you that DKA is painful. It is reported that it is so painful that you wish for a rapid death. I can only hope that Alec's heart stopped before he experienced too much pain. He was found down on the floor with a dried, foamy substance around his mouth, so we can assume that he had some sort of seizure. DKA is not always fatal, but is unfortunately, if not caught in time, to prevent permanent brain damage or damage to the heart. My son meant the world to me. He was so very special, wonderful, generous, kind human being who was meant for great things. He was not meant to leave this world so early in life. He was not meant to suffer a horrible, painful death. He was not meant to leave behind a grieving family. his amazing group of friends, and his beautiful daughter. And I've heard the bill that Senator Pratt has introduced, and we as advocates have some serious concerns with it. Number one, it doesn't include an emergency program. Diabetics often ration their own appointments due to cost, due to availability of those schedules of work and transportation. Rural Minnesota has a lack of care providers. Endocrinologists are scarce. General practitioners are not always comfortable with insulin. The time frame seems too long. Lives can be lost during that waiting period. As you could tell from my testimony, my son died in a matter of 24 hours without insulin. I'm concerned doctors already have full plates, and how can we realistically expect them to take on more? We need pharmacies to be in place for this program. Their locations and schedules seem to work better. I think it's a really good idea to encourage people to sign up for MNsure, but as we know, those policies can be extremely expensive. And I'm afraid that there has not been much conversation with the diabetic community. If you want to write a bill that can affect nearly 500,000 people, they should be contributing. Or as a non-diabetic, you have no true sense of what or how life is like and what is needed to make this program truly work. I strongly encourage you to involve families and type 1s and advocates when thinking about how you can make this bill better. I know if this was a farming bill, you would include farmers to have the best input to make the best bill possible. I think you're leaving a lot of people out with this bill. Many people on Medicare are struggling to afford insulin while in that donut hole. And I also have concerns that we're not going to be able to include people who are living close to the border states, who are actually seeking care in North Dakota and South Dakota, Iowa and Wisconsin, because they just can't get into their physicians in Minnesota. Thank you.
Thank you, Ms. Holdsmith. Next, we have Dr. Leah Grenseld, and if I mispronounce your name, please correct it when you join us at the testifiers table.
Madam Chair, Senators, and honored guests, thank you for allowing me to testify before you today. My name is Leah Greenside. I'm a resident of St. Paul. I'm a small business owner, and importantly, I'm a mom. On July 16, 2013, my then 7-year-old daughter was diagnosed with type 1 diabetes. She had been coming home from her YMCA summer camp feeling exhausted and saying her throat and stomach hurt. So my mom gut prompted me to take her in for a strep test at our local pediatric urgent care clinic. We were fortunate to get an experienced doctor who listened to me and trusted me when I said that I knew that something wasn't right with my daughter. After the strep test came back negative, he ordered additional testing and returned just a few minutes later. Well, he said, it wasn't what I suspected. Your daughter has type 1 diabetes and must go to the emergency room immediately. He must have seen the shock and fear on my face because he followed by stating, don't worry, type 1 diabetes is no longer a death sentence. Fast forward 4 years to the summer of 2017, when another mother, Nicole Smith Holt, was faced with a horrible realization that type 1 diabetes was a death sentence for her son. I don't remember exactly when I first heard Alex's story, but I remember thinking that that poor mother is living my worst nightmare, and I must do everything I can to make sure that doesn't happen to anyone else's child. I first heard about the Senate Republicans' plan for providing Minnesotans with affordable and accessible insulin from Senator Pratt last Wednesday. This plan reflects values that I believe many Minnesotans share. First and foremost, that not one more Minnesotan should die because they cannot pay for insulin, but also that doctors and patients should work together in the management of the disease, that the state should help people with diabetes to enroll in high-quality health care, and that insulin companies should be partners in ensuring that all patients can afford the insulin they need to live. As Nicole shared, however, we do have a number of concerns about possible barriers to patients receiving insulin in a timely manner through the program, particularly for people living in rural areas or with limited resources. We have other questions about details of the program, such as, will this be too great of a burden on doctors? Will all insulin types and necessary quantities be covered? And what happens if an insulin company decides not to comply? Most importantly, this plan, as drafted, is insufficient alone in addressing the insulin crisis because it does not include a solution in emergency situations. This must be addressed either in a change to this bill or through the passage of a separate emergency insulin program that moves at the same time. I want to state that I'm grateful that the Senate Republicans have made this issue a priority for your caucus. I'll be honest, we didn't always feel last session that you were listening to us, and consequently, some of you were victims of the ferocity that us mama bears unleash when we feel someone isn't doing enough to protect our kids. While all moms and parents are protective of their children, we diabetes moms are in a special class. Because of the grueling 24/7 nature of managing the disease, we regularly are up in the middle of the night checking our kids' blood sugars and Twitter. So what you should know is that while we'll show our claws if you don't think we're with us, if we don't think that you're with us, we're also quick to embrace with bear hugs those who join us in this fight. So thank you for inviting me here today, and please know that it's critically important to involve people with diabetes and their loved ones in every step as you craft this legislation. Affordable and accessible insulin is not a Republican issue or a Democrat issue. It's not a House issue or a Senate issue. It's not a legislature issue or a governor issue. It is not and should not be used as a political issue. The affordable insulin movement was born here in Minnesota because when a young person in our community loses his life, and we know that we could have prevented it, we collectively feel grief and shame and are moved to make things better. This is an issue that we can solve by listening to each other and working together to find pragmatic solutions like we Minnesotans are known to do. As a mom, I will always fight for my child, and I ask that you do too. Thank you.
Thank you. And I will tell you that Senator Pratt has taken your issue to heart and is trying to find a path forward. So thank you for helping him understand next steps. Next on our list, the Minnesota Medical Association, followed by the Board of Medical Practice and the Board of Nursing. Welcome, Mr. Renner.
Madam Chair, members, Dave Renner, representing the Minnesota Medical Association. First, I want to thank Senator Pratt and many of you who have been working on this issue to address this crisis. As been said already today, as you all know, diabetes, for those with diabetes, insulin is life-saving, and for price to become a barrier is unacceptable for people who need this drug to stay alive. Physicians have had a hard time understanding why the price of this drug has gone up so drastically over the last 5 to 10 years. While there have been improvements in the product and delivery methods, the price increases that we have seen are hard to justify. It is not an elective product, and if the prices go up too high, a person can't choose not to purchase it. So that is a serious concern for us. While this bill may not solve all the problems related to the increasing cost of drugs and insulin in particular, we commend the authors, Senator Pratt, for putting forward a proposal that is designed to try to provide a longer-term solution. As we understand this proposal, once a person would qualify for the Minnesota Insulin Patient Assistance Program, they would have access for up to 12 months. I think that's a legitimate, an issue and one that we're glad to see some continuity there. We also support the efforts to use the existing programs, assistance programs, to ensure that manufacturers are engaged to ensure that insulin gets to low-income patients who need it. Excuse me. As I understand, also one of Senator Pratt's intents is to reduce the administrative burdens that exist for those existing programs, and we have heard that from physicians too, the challenges of trying to get people signed up. So we appreciate his efforts in those areas. I do need to raise some caution, however, that while you're trying to reduce certain administrative burdens, our fear of the way this is drafted, this may create new ones for physicians and other prescribers. As proposed, the way that I understand this would work, a patient would qualify for the new program. They would go to meet with their physician to get their dosage, their prescriptions, which makes complete sense. That's the way this is going to work. But then that the They would submit that to the manufacturer, and that insulin would then be sent back to the clinic. My understanding is that that is the way many of the assistance programs may have worked in the past. From talking with physicians, less and less are using that method. And most clinics are not designed to be dispensers. While they will have some supply for samples, the issues of record keeping, the issues of storage is not what they are set up to do. Instead, what we would suggest is that you look at a different delivery model, also related to existing assistance programs, and that's more like what we do with drug manufacturing coupons. In this model, the patient would still qualify for the program, be signed up for the program, then meet with their physician, still talk about dosage and the prescription, but then the patient would take that coupon, that benefit to the pharmacy and have their insulin filled there. I think in addition to removing burdens to the clinics, it also potentially removes some confusion for patients, because many patients who are diabetics also have other medications. And the way this would be set up, you'd be getting your insulin at the clinic, but yet getting your other medications at the pharmacy. Pharmacists are designed to do the record keeping, the dispensing of all medications. We think that would be an easier way to do it. Finally, I must point out that this bill, the way it's drafted, excuse me, requires that all practitioners who are authorized to prescribe, administer, or dispense insulin would be required to participate as a condition of licensure. First of all, we don't think that's needed. We think most physicians who are treating diabetics are trying to look for any ways that they can and will want to voluntarily participate. But the way it's drafted right now, any physician in the state is authorized to dispense, administer, or prescribe, dispense, or administer insulin. I don't think we want to set up a program that physicians who don't treat diabetics are now mandated to participate and may have some challenges there. So, Madam Chair, members, again, I thank Senator Pratt and many of you who have worked on this for putting a proposal on the table to address the ongoing access. We believe there are many parts that we can and we hopefully can support at the end, and we hope to continue to work with the author and any of you to work on these issues. I'd be happy to try to answer any questions.
Thank you, Mr. Renner. Now, if I could have the Board of Medical Practice and the Board of Nursing appear jointly. And I know you often coordinate your testimony, so I will let you decide who goes first. Good morning, Ms. Martinez and Ms. Brecken. Please proceed.
Good morning, Madam Chair and members of the committee. Subsequent to the press conference on Friday, Ruth and I met with Senator Pratt, and we also met very briefly this morning with Senator Jensen. We want to have a conversation about the areas that impact the boards and just really describe some things that might be at issue. First of all, we want to say that the bill has tremendous merit, and as boards, we appreciate the importance of patients having access to their needed care. And we certainly want to make ourselves available to the authors of the bill to, as the language gets drafted and refined. Our comments today don't address all the issues. We just want to look at the sections that impact the boards of medical practice and nursing. The bill compels the boards to provide certain information to certain individuals or certain licensees who prescribe insulin and makes participation in the program a condition of licensure. I want you to know that the boards do make information available to licensees on a regular basis on our website because it provides our licensees with needed information to practice safely and in a manner compliant with the law. And some of the examples that I give you, we've worked very hard. For example, at the Board of Nursing, we have a separate web page devoted to safe practices regarding opioid prescribing. When the Department of Health contacted us with the Ebola outbreak and more recently with the hepatitis A outbreak, we worked with them to provide information and get it pushed out to nurses and advanced practice nurses in Minnesota. We use GovDelivery so that anything new that is added to our website, again, gets pushed out to those licensees who have subscribed to our website. I'm going to let Ruth Martinez really talk more about the specific areas in the bill, specifically the knowledge of individuals who prescribe insulin, participation in the program as a condition of licensure, and the requirement regarding dispensing.
Madam Chair, members, thank you. My name is Ruth Martinez. I'm the Executive Director of the Board of Medical Practice. And first, I would just like to offer my condolences to those families who have lost loved ones or who fear the loss of loved ones due to this issue. I think we are very grateful to Senator Pratt and everyone working on trying to find a way to make insulin and other medications available to patients in need. So I really applaud the work that's being done. To this bill, just a couple of points. I'd like to reiterate that the boards are really wanting to work with the legislature in every way we can to help craft some language that's enforceable for the boards and facilitates this process to the best of our ability. I'm looking specifically, I'll mention the sections in section lines 2.24 to 2.33. I just wanted to mention the language here. Initially, the Board of Medical Practice and the Board of Nursing shall inform licensees who are authorized to prescribe prescription drugs. I would invite repeating that broader language as opposed to a little bit further below in line 2.30 and 2.31, which is specific to insulin, primarily because we do not have any knowledge of who may or may not among our licensees be prescribing insulin, any more than we would know who's prescribing an antibiotic or birth control medication or even a controlled substance. So just wanting to clarify that all licensees who are physicians are authorized to prescribe prescription drugs, including insulin. So just a clarifier there. And I think my suggestion in that section would be to just, at line 2.29, I'll just read, the boards shall also ensure that licensees are provided with information on the Minnesota insulin program, and just take out the who prescribe insulin section. Then I just wanted to move forward to hop over a couple pages to section 4.8 to 4.11. This is the section, you may recall, that speaks to authorizing those who prescribe, administer, and dispense under section 151.37. I would suggest modifying line 4.9 to say authorized to prescribe, administer, or dispense, because not all individuals will actually be administering and dispensing. So they may be prescribing. We just want to make sure that we capture the intent that whoever is administering and dispensing will also be captured. So I would just change the and to the or. And again, I would modify that language to just say prescription drugs, because section 151.37 references prescription drugs. So I think it's aligned with that section of statute that it's reciting. And at 4.10, stating that these individuals must participate as a condition of licensure seems unnecessary. These are individuals who are, as it already states at the beginning of line 4.10, are licensed and practicing. I would simply put a period after must participate in the program and not state it as a condition of licensure, because that, to me, implies that we would need to know that before we issue the license, before we grant the license, and we've already stated that these individuals are, in fact, licensed and practicing. And I'll jump ahead just to lines 4.22 and 4.23, where it references upon receipt of the product from the manufacturer, the healthcare practitioner shall administer or provide. I would suggest expanding that language to say the healthcare practitioner, healthcare organization, or healthcare entity, which I think is compatible with, I think is it 340B? So I just wanted to make sure that we're inclusive of the entities as well as the individuals And I think those are all the comments I had, unless Ms. Brecken has some additional. Thank you.
I just have a prescriber question. I know that we have some categories of prescribers who are prohibited from certain types of prescriptions. Am I correct? There's some advanced practice nurses who can do a level of prescribing, but insulin would never fall into a restricted category. So if you have prescribing authority, you could prescribe insulin. Is that a correct understanding?
Madam Chair, that's correct.
Okay, thank you. All right.
Madam Chair, thank you. I should have mentioned that we also regulate the physician assistants who may also have prescribing authority. I'm sorry for not mentioning them earlier.
Thank you. Ms. Martinez, though, that would be inclusive in the language that's before us? Okay. Thank you very much, both of you. And members, we can recall testifiers as you feel the need. Next, we're going to move to public testimony. I have Jim Robleski and Alexis Stanley. I do want to make a note, MNsure is going to be an important part of this. I spoke to them a couple of weeks ago, and they're willing to help develop something, but because they have a large commitment that fell on this day and the shortness of the notice, they were not able to send someone. So don't take the absence of MNsure as a lack of interest, just a calendar conflict. So Mr. Robleski.
Thank you.
Welcome to the
Chair.
committee. Please state your name and proceed.
My name is Jim Robleski. I'm just a regular guy who found out about this meeting and would like to share with you some thoughts on the costs of insulin. I'm a type 2 diabetic who has got into the pricing of this drug as a result of my Medicare supplemental Part D plan, putting my insulin from a tier 1 to a tier 3 or 4. So the costs for me went up to about $10,000 a year, of which my plan paid part and Medicare paid part. I'm very concerned, just to get to the point, about any tax implications that might come as a result of any bill made to assist us with insulin. And then, which begs a question of why we're paying so much here, and I can drive up to Fort Francis, Ontario, and cut my costs by 90%. So under Medicare, I have a coverage gap in my $10,000 bill of $5,859.80, of which, due to the coverage gap assistance program that Medicare has, the Medicare pays $3,691.68. That's taxpayer money. So I go to Canada and I can save $4,374 from my own, but I also save that $3,600, $3,700 of the taxpayers' money. All of this gets to the point, and I know this is a difficult question, and it just shouldn't be a difficult question, of why we're paying 10 times the amount here that a 6-hour drive can alleviate for me and everyone else. I understand, especially reading Pharma's letter here that was available, that research is an important thing. I have an undergraduate degree in biochemistry and a master's in business from the university, and I completely understand the costs involved with doing research. But the fact is, one of the insulins I use, which is Lantus, is a 29-year-old drug. It's well out of any kind of patents, and I just find it difficult to accept that it costs that much and increases in cost for the same vial that I could have bought in 1990 that I can buy today. And I understand inflation and all that, but I still don't understand why it's costing me so much. And so with that, I'd like to leave those questions on your minds and hope that you would take serious consideration that the first thing to do when introducing any bill might be to look at the underlying cost issue far more than which program we we put a very expensive drug into the people's hands. In fact, I would say anybody's welcome to come to my house if they need insulin that badly. But why we pay so much is just beyond me. Thank you very much, Madam Chair.
Thank you, Mr. Wroblewski. Senator Marty.
Just a real quick question. Mr. Wroblewski, you said the cost of Lantus from 1990 till now, you didn't give us any numbers. I was just curious how much it would have been then, how much it would be.
I'm sorry, I just don't know the pricing, and that's one of the issues, is we don't have easily available information relative to pricing, why it costs so much, what it might have cost. I can say that the prices, I have some data on the last 5 years, the graph just keeps going up, and there's no reason for that, for this particular drug, in my view.
Madam Chair.
Thank you, Madam Chair.
Senator Jensen.
Could I just make a comment to Senator Marty's comment? Question?
Quickly, yes.
Yeah. In about 2000, it cost about 2 cents a unit of insulin. And in some scenarios today, it's between 35 and 40 cents per unit.
Senator Nelson, quickly to this point, we're going to have member questions after public testimony, but if it's to Mr. Wroblewski. Yes.
Thank you, Madam Chair. And Mr. Wroblewski, thank you for your testimony. And I appreciate many of the comments that you said. And as we seek to make sure that every Minnesotan has the ability to get the insulin they need, and we're concerned about the skyrocketing costs, I appreciate the fact that you also noted that there is R&D. And we're counting on our R&D to bring us cures for diseases that are affecting us now, and life-changing cures. And so while we hold down prices, we also don't want to suffocate research and development of new life-saving drugs. So I appreciated that your comments acknowledge that. And you also mentioned another aspect that is so, I think, we haven't discussed that enough. And you talked about driving 6 hours, 6.5 hours to Canada to get the insulin at a much lower price. And I recall several years ago when I was first in the House of Representatives, at that point, Minnesota, under the direction of Governor Pawlenty, set up a mail order that allowed Minnesotans to import drugs from Canada via mail order. I have a similar bill that I introduced last year, and I'm hoping to get some work on that as we get into the next session. Do you would you find something like that helpful, or if you were in need of insulin during those earlier years, I think in the early 2000s, mid-2000s, did you use a mail order program for drug importation from Canada? And I just am curious if you found any benefit or would find benefit in that.
Mr. Wroblewski?
Oh, Madam Chair and Senator Nelson, I really I haven't used the mail order possibility to date. Mostly because I have a good friend on Rainy Lake who allows me to go fishing, and so I just drive across the bridge. So,
much more fun.
It's one of those things. But I believe, especially during winter, I would more than likely and probably will use any kind of mail order facility to do the same thing. I noticed in last week's paper there was an ad by a Canadian firm that allowed these kinds of mail order activities to take place, and I really am not aware of the statutory restrictions of what comes across the border or what the federal government might or the state government might put together to restrict that. But so far, so good. I just drive over and come on back, and nobody seems to have a problem.
Thank you. Thank you very much.
Thank you, Mr. Wroblewski. Alexis Stanley. Oh, I'm sorry,
May I make
Mr.
one
Wroblewski.
comment, Madam Chair, is that relative to the research, I'm very empathetic to any corporate need to do that. But I just want to say that I think if Sanofi, who makes Lantus, which is the drug I'm talking about, if they're doing business in Canada, they must be making a profit. That's all I want to imply, is that 1/10 of the cost here, you know, I would love to know what research I'm paying for. And that's all I'm looking for, is some transparency. Thank you, Madam Chair and committee
Mr.
members.
Wroblewski. And Senator Rosen has a transparency bill that you might be interested in following as well. It will be coming up early next session.
Thank you very much.
Thank you. And I apologize, Alexis, if you would join us, please, at the table. Ms. Stanley, please state your name for the record and proceed.
Madam Chair, committee members, thank you for allowing me to share my testimony today. My name is Alexis Stanley. I'm 20 years old, and I was diagnosed with type 1 diabetes a year and a half ago. I was in diabetic ketoacidosis, what Alec faced, when I was diagnosed. It was one of the most draining, exhausting, and the worst feeling I've ever felt. I was in the ICU for 2 days on an insulin drip, bringing my blood sugar down. I was over 700. I spent 5 days in total in the hospital. After that, I was given an endocrinologist to help me manage my new life, everything. In my year and a half of being diabetic, I have seen my endocrinologist 4 times. You're supposed to see them about every 3 months. Mixed with my busy schedule, I'm a Division II athlete, I full-time student, worker, part-time, and her availability. What happens when I need my insulin from my endocrinologist and I call and she's booked out? I called this past June. I can't get in until November. What happens when I have a month left of my supply and I can't get in to see her for however many months? I'm 6 years away from being off my parents' insurance, and that scares me as well. When I turn 26, what happens if I have a job that I make just over $50,000 and makes me unqualified for this plan? Just because I make more than 50 grand a year does not mean I have the resources to obtain my life-saving insulin. This plan, although I'm happy to see something being worked on, is not long-term. What happens when I go in for my prescription and I can't afford it? Will I get stuck rationing my insulin like Alec? Will I turn into another statistic, join the other 1 in 4 diabetics that ration their insulin because the price is insanely high? What about emergencies? This is a good start, but it doesn't erase my fears, and I, along with the rest of the diabetic community, need something that does. Thank you.
Thank you. Alexis. And just so members know, CMS is promulgating rules about reimportation right now, and Florida has moved a bill about reimportation. We're looking at that closely, that those two things working together, we could begin working on reimportation to make some fundamental change in the prescribing system. I reached out to the governor in June to ask for a meeting about it and hope that he will engage on that issue as well. And so with that, members, we have completed the listed public testimony. We are starting a list, but
Okay. Now, I wanted to say
Senator
that there is
Whitman.
another person here. Kim Munson would like to speak, and if she could be part of the public testimony, I would appreciate it.
absolutely. And as a courtesy to Senator Wicklund and the amount of work that she has put into this, I would ask you to invite her up so that she can introduce herself to the committee.
Thank you.
And for members of the public, we requested that an email be sent to Ms. Strand, and but as a courtesy to Senator Wicklund's work, we wanted to make sure if there was somebody she was particularly interested in, that she could come forward.
Okay, good morning, Madam Chair, and
please introduce
yes,
yourself for the
absolutely.
record, and we're asking for about 2 minutes, and
Okay,
then members will
for
have
sure.
questions. Thank you.
Thank you, everyone. My name is Kim Munson from Lakeville, and I actually didn't prepare a lot, but I do have some questions. And first off, though, I really do want to thank those who came together over the summer and the Republican caucus for coming to an agreement that this is an issue in Minnesota and that Minnesotans with diabetes are frightened and scared that this is an issue and that people are dying. I have an 8-year-old daughter with type 1 diabetes, and while we can afford her insulin, I'm really concerned about her future as a person with diabetes in Minnesota, especially as I see the trajectory of insulin prices over the past 20 years and in the future. So again, I said thank you. I really think that we are perhaps turning a leaf. It's autumn, the first day of autumn today, so maybe this could be the start of a new future. A couple things I wanted to comment on. I really did like the dependent child notice in your bill, the fact that you are going to be notifying children or the dependents on insurance plans shortly before they turn age 26. I think that's a really smart idea, especially for people who might not be aware of what's going to be happening at that particular age. A few things, though, that I wanted to just encourage you to consider further as part of a larger, broader message I want to share is that I would really want us to have a larger conversation ongoing about this bill that includes diabetes advocates and families of type 1 diabetics, not just today, but in the future across Minnesota. And I come at this mostly because I am not from the Twin Cities. I am originally from the Red River Valley. So when I first read the bill, immediately I thought, okay, how does this apply to me as a resident of Moorhead, Minnesota? And knowing that throughout my entire life, I would travel to North Dakota for care. And perhaps this is something that Senator Jensen, as a physician, would know. I don't know what the reciprocity is as a physician, but I'm thinking about all those people in Minnesota who are traveling primarily to North Dakota who get care. I don't believe the requirements as a physician would, I don't think we can legislate North Dakota physicians. I don't know, but what does that mean from a bill perspective? So that's something I would just ask you to consider as you're working through this. Another thing I would just ask you to consider specifically about the requirement to prescribe insulin. To me, as I read this bill, it looks like you have to prescribe insulin if you are a physician in Minnesota. And I just think back to my mother, who was a nurse for 40 years. She worked at a nursing home, and when Kinsley, my daughter, was diagnosed with diabetes, she really hesitated to give her insulin. In fact, she never once gave Kinsley insulin. My mom passed away last year, but even though she was a nurse, she felt uncomfortable because insulin can be lethal. It is a very potent hormone, and if you give too much insulin, you can die. And as we have learned, if you don't give enough insulin, you can die. So I would suspect as a physician, there are some people who do not specialize in diabetes or feel comfortable, maybe they're a mental health doctor or whatever, they may not feel comfortable giving or prescribing insulin. So that would be another thought I would have. It just seems unrealistic maybe to have that language in the bill. Another thing I noticed is that there's no manufacturing timeline requirements, and I think this is a big concern of mine. This is probably the biggest concern I have of mine. I think we should be looking at Senator Jensen's bill last year, the PBM bill, where he had mail order requirements state 5 days for mail order pharmacies to be sending back drugs to patients. We need to have similar language in this bill that requires these manufacturing companies to be sending drugs back to, if it has to be the doctor's offices, the doctors. I don't see that in this bill, and I think that's really important. So if we want to get insulin in the hands of people, we should be doing that. The last thing, I wish that we didn't take pharmacies out of this equation. I really agree with Senator Jensen. I think it's good that we are getting doctors involved. Doctors, we go to Children's, they're really paramount to the care of my daughter and her care. I appreciate them a lot. We value their, they are integral to the part of, making sure Kinsley grows up healthy and strong, and that we can, that she, as she grows into an adult, can take care of her diabetes on her own. But pharmacies are open a lot longer than doctors. I know it takes us like 3 months to get into an endocrinologist. So I would just encourage you to consider rethinking having doctors be so a part of this. They are so overworked, to me, it seems. Administratively, we have CDEs that it takes them a couple days to get back in touch with them. They work really hard. And if there's any way we can get pharmacies to be included in this conversation, I would encourage that. So those are some of my initial thoughts. I really look forward to additional conversations across the state. Thank you.
Thank you, Ms. Munson. And any questions for this testifier? Okay, thank you, Ms. Munson.
I have a question,
And then
Madam Chair, for Ms. Munson.
testifier, go ahead, Senator Jensen.
Thank you, Madam Chair. Thank you, Ms. Munson, for testifying. We're going to get into more details as we go along, but I would like to follow up on your point. I think you're absolutely right. Pharmacies, in terms of being able to meet the patient with where they're at in a situation where there's desperation. I know that there's rules and regulations, but a lot of times it's in the local pharmacies where temporary adjustments can be made. If we had a situation where someone was desperate for insulin and we did have the pharmacy involved in perhaps the actual provision of the insulin to the patient, perhaps the forms would have already been sent in, but for whatever reason it was the 4th or the 5th day and we really needed that insulin. We sort of do that in the offices with the VFC program for vaccines for children, where sometimes we'll have someone and they're in need of a vaccine and perhaps they're on an MA program. We will, if you will, borrow a dose from one of our paid-for vials for commercial and give that vaccine, and then we'll just pay it back when the supply comes from the state. I can see pharmacies doing that, and since we're talking about trying to save people's lives, I think you make a very good point that to have the pharmacy be the one, because it's conceivable where I could see a pharmacist say, well, I know I sent the paperwork in, so it's going to be here tomorrow, if not today. I will do this. And pharmacies do that around the state. They do, without our knowing it, they do at times save people's lives. So I think we need to cogitate further on your suggestion. Thank you.
I appreciate that. Thank you, Senator Jensen.
Thank you, Ms. Munson.
Thank you.
And now members to our list. There seems to be a misconception. This wouldn't prohibit, if you have a prescription, you going to the pharmacy, but if you couldn't afford your insulin and wanted to participate in this program, the goal was to get you in touch with the doctor and make sure that it was managed. But because there is a longer term eligibility, I want us to not, I want us to look for possibility in this bill and improving it. So thank you, members. We have Kiffmeyer, Abler, and Marty. Senator Kiffmeyer.
Thank you, Madam Chair. I agree also. I appreciate Senator Pratt and all those who worked on this, including Senator Jensen, you, Senator Benson, and others as well. We, without question, appreciate that. It's also so really good to have a hearing on this so you can openly have the conversation, hear the value of our testifiers. We really appreciate your feedback, such as the concept of a coupon. Still having, I think it's critical to have the family doctor involved. Diabetes is a lifelong to deal with, so it's unique in that respect. So having that connection is so important. And then the pharmacy connection, the method, if a coupon is the method that works better and helps to accomplish it, then I'm all for that. One of the things that Mr. Odusky discussed about was the change in Medicare from classifying this as a Tier 1 to Tier 3 or 4. Do we have any information or studies in regards to why did it move from Tier 1 to 3 or 4? It's a long time medication. It really affects a particular group of people, seniors. So do we have any information on that, or can I request that we find out from CMS on why did it go from Tier 1, 3, 4, or verify the fact that it did, first of all, and if it did, why did it? And I think to even ask them to not do that, to go back to a Tier 1. It is a critical drug.
And Senator Kiffmeyer, I believe he was talking about a supplemental, and we can't, his Medicare supplemental. I'm looking for, Mr. Robleski, would you please clarify, did your supplemental plan move it from Tier 1 to Tier 4?
Good question.
Or is it for your Medicare benefit overall? Just so we're clear, members, we can't do a lot with Medicare, but we can find things out and put pressure on Congress.
To clarify, Madam Chair and Senator Kiffmeyer, in 2017, the drug was a class or a Tier 1. In 2018, it went to Tier 3. And I just checked before coming out last evening that's back to Tier 1. Is that it's a mystery as to why. So thank you for asking that question. I suspect.
Further question, though, Madam Chair. Yeah.
Okay.
Senator Kiffmeyer.
I think, Mr. Ondusky, while you're here, was the classification of the tier from CMS, from Medicare, or was it from UCare?
This was the supplemental plan at UCare that did the classification.
Thank you, Mr. Robleski. And I think every supplemental plan, I don't want to call out UCare in particular, they're a partner in how we provide care in Minnesota. Mr. Robleski.
And Madam Chair, again to clarify, all the available programs for me under the Medicare supplement moved the drug. There was no plan I could buy where last year it was a Tier 1 drug. So this, again, made me, caused me to investigate prices deeply. So thank you.
Thank you, Ms. Robleski. Anything further, Senator Kiffmeyer?
Well, I just think that this is an area where it's multifaceted, and it's important for us to understand why or where or how come, whether it's a Medicare Advantage plan, supplemental plan, whether it's Medicare itself. I agree with you, but I think since he had testified, I thought it was important for us to have that piece of it as well. That's very important. But I think nonetheless, that answers my question for the most part. And by the way, I do think, Madam Chair, that when we have these discussions in the legislature, both on this House, Senate floor, and here today, the plans and others are not ignorant of that discussion. And sometimes by having that discussion, it can impact them in their decisions that are theirs to make, but may contribute to saying, oh, this is receiving a lot of attention, let's go back to Tier 1. So sometimes that effect comes about, and hopefully maybe that it will stay there permanently, because that's for those people who get their insulin through that methodology, it's important. But whether it's Canada or mail process, all hands on deck, whichever way works, because our patients are all different. The young ones, the teenage ones, those are going between 20 to 30, they're all different, and we're trying to think of something that takes care of them all. Probably my question, though, for Senator Pratt has more to do on that theme. This is one area that we've talked about right now, but this bill is not the only effort that the legislature has made. Would you just summarize what are some of the other ones? It's only been a few months in session, but what are some of those other things that we have done to also work on this cost of this medication and others? If you could just summarize what that is so I have a total picture.
Thank you, Senator Kiffmeyer. I'll excuse you, Mr. Robleski, and Senator Pratt, if you'd like to answer Senator Kiffmeyer's question.
Thank you, Madam Chair and Senator Kiffmeyer, and I have tried to avoid this committee as often as possible. And I have seen a list. I don't have it on me at this moment, but I do know that we've talked about insulin transparency. We passed a bill last year that said health insurers could not profit from insulin sales. I know just as early as 2017, the state of Minnesota was profiting off of insulin sales, where we were receiving more in rebates than we were paying out in reimbursements. And I found that to be extremely troubling. I believe it's the reinsurance that we passed in 2017 and renewed this year has helped control and reduce the cost of health insurance premiums. Unfortunately, we passed that too late for ALEC. So those are some of the things, and that's why we're seeing these copays come down and be capped at $25 you know, it was interesting to me as I started working on this plan back at the end of July that it changed. It seemed like the landscape of this issue changed from week to week as new insurers came out with programs to help address insulin affordability for their customers. And so I think it's been a combination of legislation. I think it's been a combination of stakeholders within the medical system to help bring this issue. It was certainly an issue of high import during the last legislative session, and I think everyone in Minnesota, everyone who touches this was affected by it.
Okay, Madam Chair, thank you, Senator Pratt. Madam Chair, just wondering, do staff or other members of our committee, I know they've sponsored bills, they've had bills, can address, what are some of the other things? The main thing is that we're going to take a look at this picture, whether it's Medicare Advantage or other things like that. We've worked on this piece. Who else or somebody, staff or committee or committee members could have additional knowledge about what I recall one of them was emergency refills as well?
And Senator Kiffmeyer, so Senator Wickland had an emergency refill provision for life-saving drugs. So if you break a vial or if you have a cloudy vial or something, that you could get a 13th dose in a 12-month cycle that would be covered by your insurance. So that was a Senator Wickland provision. Reinsurance, 18% of the reinsurance claims had a diabetes code related to them. Reinsurance impacted the insulin-dependent community greatly. The removal of profit from rebate sales as it relates to rebates was moved as well. I think Senator Jensen's pharmacy benefit bill is going to not impact immediately, but it's going to make it more clear the impact that rebates are having in our market. And I think Senator Rosen's bill, which I keep hearing is getting worked out on transparency, is going to help open up the conversation with fact-based discussion. Mr. Blesky pointed out nobody understands why the prices are doing what they're doing. And so we have significant provisions. We wanted to impact the entire market of pharmaceuticals. We can't move fast enough to impact the insulin market. And Senator Pratt has decided to take that on personally and champion that cause. And as much as he doesn't want to be in this committee, he cares deeply about getting this right. We're going to keep moving on questions. So we have Senator Abler, Marty, and Franzen up next. Senator Abler.
Well, thank you. And I think Senator Wickland was up on too. If you could move me past Senator Wickland, I was waiting I'll have less questions if I hear their questions. So thank you.
Okay, Senator Wickland, you can have Senator Abler's spot. Senator Wickland.
Okay. Well, thank you, Senator Abler. I appreciate it. And I guess first I'd just like to say thank you for having the hearing today and having an opportunity to be able to hear testimony from the insulin advocates who came. I mean, I think it's really powerful to hear and challenging for us to hear stories of their lives, and especially thank you to Nicole for coming forward and again telling your story about Alec. And I hope that it keeps us all motivated to looking at, what are the problems we're trying to solve here, because we know Minnesotans are impacted every day with the high prices of insulin. And so I appreciate the opportunity to hear from them and for the whole committee to hear from them. I guess my first thoughts about Senator Pratt's bill, I think that there are definitely positives to securing a way for insulin, for diabetics to have a sense that they have a year that they will be able to get their insulin at no cost. I certainly think that would be great if that's the way the program will work, and then it meets those needs for over a year period of time. We know that stability and having your insulin access regular and just as your doctor prescribes it is really important. So I think that part of the bill, I think, is really beneficial. I think the concerns I have about it really relate to the emergency access part. To start with, I think the timeline for someone to learn about the program, to enroll in it, and to actually get access to that first refill, it sounds like it could be short, but really there's not any constraints on how long it could take. So I think that we still need to find a way to address those who are in a situation where they need insulin in an emergency basis. So I heard that you said that that's something that you're continuing to work on, and I hope that we can continue to have discussions about that. You listed some things you thought were not desirable about the work we've been doing on the Alex Smith Emergency Act. And I hope that you'll be listening to the House hearing this week to be able to hear more fully about that. Yes, that it is geared to be a 90-day supply. However, there is discussion based on our work this summer that in the working group that we would be intentional about putting people in contact with other ways to get a more stable supply of insulin. And I think that is really important, that people get connected to providers and to insurance coverage. The setup period of 9 to 12 months, I don't think that that's accurate. I think that we are working on something that is administratively easier to set up, and it wouldn't take that long. So I guess the questions I have for you relate to, part of the question, I guess, is on this administrative action that's needed to set the program up. I mean, I know that you have indicated that you think it could be set up in 60 to 90 days, but I'm wondering who is actually responsible for the administration of the work in terms of getting the program started, getting the forms set up, who would be responsible for that. There's mention of the commissioner being supplied with a fax number from the manufacturer. I'm wondering which commissioner is that, and is that commissioner responsible for coordinating the activities to get the program running? And yeah, if you could address that first. I have other questions.
Well, thank you.
Senator Pratt.
Thank you, Madam Chair and Senator Wicklund. I think to your last question first, it's the Commissioner of Human Services, but we would be relying on MNsure. This draft puts in a dollar amount of $250,000 to get the program up and running and create public awareness so that we can get that discussion out there. It would require the building of a landing page at MNsure in order to get to do the eligibility. We would need to make sure that we have a very thoughtful discussion around how that workflow within MNsure works. I've reached out to MNsure and been trying to set up an appointment in as well, and I know that they are extremely busy, and we're still working through that. You know, as far as, thank you for acknowledging that, you know, I understand that this doesn't include an emergency program, but, and I know that this idea won't eliminate the need for emergency supplies either. I just found through our discussion in the bipartisan working group over the summer that I thought the House bill was insufficient in that when I asked the question, I was told we hope we can find something for these patients to do. I'm just going to react a little bit to, you know, when I've talked, I reached out to Ms. Holt-Smith before this plan was developed. I've talked to people living with insulin in my church, my community, all summer long. To say that I haven't been listening to people who are affected by this is incorrect. What I have been really upset with is the hyper-politicization of this issue. And so forgive me if I tried to step away from some of that so that I could think clearly, so I could work through some of this without the noise, the rhetoric, the attacks. This bill, while it won't remove the need for some sort of emergency strategy, I think the hope is that if we can connect people to their supply of insulin before they're in crisis, before they start rationing it, we will save lives.
Thank you. Senator Wickland, anything further?
Yeah, I guess just so it sounds to me like the enrollment setup, the landing page and what that it would accomplish. Have you talked to MNsure about whether they will be able to host enrollment for a non-MNsure marketplace product on that website? It sounds like they would be charged with creating the enrollment process for that. I guess when I talked about administration of it, I don't think MNsure, their actions today really relate to program implementation to the level of setting up a form and a process for providers to use to communicate with the manufacturer about insulin. So I guess I'm asking you, who is going to do that part? So there's two things. MNsure, have you consulted with them that this program can be something that's added to the MNsure website?
I believe Senator Benson's had, oh, I'm sorry, Madam Chair, Senator Wickland,
Senator
I believe
Pratt.
Senator Benson's had some communications with MNsure. I've been reaching out to MNsure, trying to get that. I've been unable to schedule some time as of yet to meet with them. It seemed to me that we needed to get this bill and this concept out there as quickly as possible to continue the discussion, especially if there is a sincere desire to move this forward before the beginning of next session. And so, yes, I am still touching bases, and I have made attempts to reach out to them, but no, Senator Wickland, I haven't had a chance to meet with them specifically about this bill and the administration of it.
Okay.
Senator Pratt, Senator Wickland, I don't want to publicly characterize what MNsure conveyed to me in a private phone call, but I'm happy to explain to you the progress we've made in the conversation. But without them being here to speak for themselves, I'm uncomfortable characterizing what they said to me in a private conversation. But after the committee today, I'll tell you what our conversation was so that you can engage on this. Okay?
Yeah, thank you, Madam Chair. And I guess that is an area that I hope we get a much fuller discussion of how that would work and an actual implementation of it, because I think putting a timeline on it of 30 or 60 to 90 days without having that discussion and that understanding of what systems development work is actually required, I think is, I think you're putting out there something that as being a short term to implement, and we don't have the full picture, full description of how the process would work. So I have concerns about that. And I can start with my questions there, and then maybe if I think of more, I will have more later. Thank you.
Thank you, Senator Wickland. And then to Senator Marty.
Thank you, Madam Chair. Senator Pratt, I again applaud that you're trying to bring something forward. When you were discussing the differences between this and the Wickland bill, you said this does not contain emergency provisions. I thought that was one of the reasons for doing an emergency, very quick hearing and everything else was to deal with it. I didn't see the bill language till this morning. But I think this is worth doing regardless of whether an emergency one is. But again, Madam Chair, I hope we can get to Senator Wickland's bill hearings on that, because I think that one is the one that deals with the emergency thing. But Senator Pratt, what I'm wondering, and you said you started working on this in late July, I know Senator Little had pulled together that task force trying to break down the partisanship, and I know Senator Abler was there, Senator Wickland was there, Senator Little, Senator Jensen, myself. I saw you at least one of the meetings. I guess I'm wondering, did you feel we weren't making progress in that? Because I thought there was pretty much agreement on everything over one, except one major point, and that is who pays for it. But the rest of it, I thought there was, what I was hearing was everybody in the room saying they were fine with it. There were a number of House authors. There were at least, you were one of at least 3 Republicans I know, and I think I remember 3 Democrats. That doesn't mean everybody in the Republican Party or Democratic caucus would agree with it, but did you have problems with that? Was it, you didn't, because that's an emergency one, which is what I thought we were trying to get at.
Senator Pratt.
Thank you, Madam Chair, and Senator Marty. Maybe I took a little bit different approach to it, right? Even when we put forth the op-ed back after special session, the issue I heard was insulin is unaffordable. And so I attacked affordability. I want to make insulin affordable to patients that need it. Now, and if we can make it affordable before that patient is in crisis, it seems to me that that's a better approach than waiting until the patient is in crisis, providing them a 90-day supply, and then not having a robust answer after 90 days, because insulin doesn't become any more affordable after day 91. Because of my schedule, I attended a few of the sessions over the phone and a few of the sessions in person. And in the last session, I had suggested that we not break up the bipartisan working group because we hadn't discussed, I think, in any level of depth how to pay for the program. We kind of threw up our hands and said, well, we don't agree. I had asked specifically before we broke up, how do we address day 91? Dr. Jensen brought up whether or not this was a temporary or permanent solution, and in the draft of the framework that I got, that was never addressed in that framework. So to say that the working group broke up with only how to pay for it as the open issue, from my perspective, I would disagree with that. I laid out the items that I had concern with as we were doing that, and I was more than willing to continue to work. In fact, I met with Representative Howard shortly after that working group broke up, and he was the one that suggested, as we talked through these issues, maybe the Senate ought to go out and develop their own plan so that we can have a conversation. And quite honestly, I thought that was in some ways that became a freeing suggestion, because that allowed me to think outside of the box and the constraints of what we were dealing with when we had that specific bill in front of us, that specific bill that had generated really so much partisanship that we needed to step away.
Madam Chair, Senator Pratt, I guess I think the whole purpose of those summer meetings was to have the bipartisan group sit down together and do it, and it seemed to me that the only dispute I was hearing on the emergency portion, which is what that bill was, the only thing it was to do. I don't think Senator Wickland, Senator Little, I don't know anybody who said that that was the whole solution to the insulin problem. I agree with you that the problem is, I'll call it rip-off pricing. When Mr. Robleski says you can get it for 1/10 as much in Canada, and I think he also is the one who said, and they're not selling it at a loss in Canada, they're selling it at a profit in Canada. And for drugs that are 15, 20 years old, some of them off patent, the fact that they're charging this much, that's the problem. But it strikes me as your bill saying, well, we're not going to deal with the emergency here. That's why we ought to get to the Wickland bill and deal with that. But my concern is, if we're going to address the pricing, what you've got here is basically a system which would take a lot of people up to 400% of poverty, which is wonderful. I like that. But say that they're going to get a year of, they may well be qualified if they're under 400% of poverty, and they go through this process that they get a year of free insulin, which is good because the pharmaceutical industry, which I would argue has been way overcharging, at least they're giving something back. But the way you're doing it, it strikes me you're making every physician who comes into this situation to be, they're the pharmaceutical manager. They're the ones they have to, when they receive the patient's statement of eligibility, they have to submit the statement, unique ID number, a whole bunch of other things to the manufacturer, and then all these other, a whole list of 4 or 5 things, including days when deliveries are not accepted by them. Then the manufacturer ships it to the doctor, I understand, and then the patient either comes into the doctor again, and then the doctor prescribes it, and they have to fill the refills for 4 times in that year. I don't know. I'm not a doctor. We only have one on the committee, but today. But I can't picture doctors thinking it's great that they get to be pharmaceutical dispensers now. And so this is a way saying we're going to have the price. We're not doing anything to change the price here. All we're saying is for anybody under 400% of poverty, if they go through their doctor being the pharmacist, they can get a year of free stuff. And I'm not sure that that does anything to bring down the prices. And if we had fair prices, I don't think we'd have the emergency bill need either. I mean, if you have the prices you had 15 years ago for these drugs, you wouldn't be having Alex Smith situations. You wouldn't need the emergency thing because there are enough other ways and there are enough other people who could find a way to fill the gap if it wasn't so much, if it wasn't, I think, one of the folks said it was like $6,000 to $7,000 a year, I think it was, for how much it is for insulin. You wouldn't have that problem. If it was $300 or $400 a year, you could cover it, and parents could cover it, and others could help. But I'm just wondering, first of all, you're saying that your bill does not deal with the emergency. Are you saying that we should do the emergency, or saying put the emergency bill off till later?
Senator Pratt.
Thank you,
And then
Madam
Senator
Chair
Kiffmeyer.
and Senator Marty. What I said is absolutely I said that in my opening remarks, that conversation can and should continue. But the point is that as a healthcare committee, well, let me take that back. If we can take a significant portion, I don't know, 80, 90% of these cases, and if we can resolve them before that patient is in crisis, before that patient is down to their last few doses and has to decide whether or not to ration, wouldn't you agree that's a better option? And this is not a permanent solution, Senator Marty, because this isn't addressing the issue of drug prices. This is a stopgap measure to help people who are struggling to afford insulin get the life-saving drug that they need. And it takes a little bit of effort. But we're using an existing distribution channel, I like to call it direct-to-consumer, through the doctor, that exists for the patient assistance programs that the pharmaceutical companies are running today. And so why create a new distribution channel when one already exists?
Madam Chair.
Senator Marty.
Senator Pratt, when you said you listed key differences between your bill and the Wickland bill, which again, you and I and she and I think everyone would agree are different purposes. Hers is an emergency one, which is why we really would want to do something before the next session. But I'm not disagreeing with what you're trying to do. I'm saying it's a reasonable thing. But one of the things you said was her bill creates a new bureaucracy and yours doesn't. I guess when I see that by January, the MNsure is going to have implemented on its process a way that they can have an application form and they can, within 5 days of receiving a completed application, provide an eligibility determination. That strikes me as, I'm always amazed how much technology changes at state agencies and MNsure and other places cost. But you're saying, oh, there's no money for that. That doesn't cost anything. It still is a bureaucratic change that has to be made. You're saying the doctors are going to do the pharmaceutical dispensing and so on, which is an expense to somebody. It's not here. But I just, again, I like the general idea if we can get the pharmaceutical industry to pay to provide some free stuff since they've been overcharging everybody else so long. I understand that. I'm just wondering why you think that this is even close to ready for prime time, since I think you said you tried to set up a meeting with MNsure, so you haven't talked, that implies you haven't talked with them yet. It strikes me that the changes we wanted them to do last session take a lot of time to program into their computers if they're even allowed to do that. And do you think that, you feel this bill is close to ready, or?
Senator Pratt.
Thank you, Madam Chair, and Senator Marty. There are some significant differences in how this bill is run versus how the working group bill was discussed, in that would require contracting with a PBM and going and doing all sorts of that. As I talked to the stakeholders, and I'm trying to remember who I spoke with, it's leaving me that that's a several-month process to get up and running to do that that bid. That being said, I do believe that this is ready for prime time. I'm not saying that there aren't some details that still need to be worked out, and there are having this hearing is to identify some of the issues. But I clearly think that, and I've not shied away from the emergency piece, and we can continue to hammer on the emergency piece, Senator Marty, and not acknowledge that this bill prevents people from getting into crisis and needing emergency supplies. But and I've acknowledged from the very beginning that we need to continue to have that conversation. And I think, as you've rightly pointed out, there are two different issues here. One is insulin affordability, and one is emergency access. And emergency access is a short-term fix, and Senator Marty, this is a fix that makes sure that patients have a sustainable supply of insulin until we can get them enrolled into an insurance program. One of the main objectives of the ACA and our MNsure legislation, and quite honestly, we're still falling short on that. It hasn't done what it's supposed to do, and this is a way to identify those customers and get them back in so that MNsure can be out there contacting patients as far as what they are qualified for.
Madam
Okay,
Chair.
thank you. And if I could, Senator Kiffmeyer has a question to your point. Senator Kiffmeyer.
Well, thank you very much, Madam Chair. I look at this more as an urgency bill than an emergency. Emergency is in those next few days, but I will tell you this. As a nurse for diabetics, having stability and consistency and having a longer term that they can take a look at this and say, okay, for this longer period of time, I can have some consistency and stability. That is an urgent need. This is an urgency kind of approach to take, and I think it's as critical as an emergency. I know, Senator Pratt, your heart is also in regards to emergency, and that can readily be addressed and should be addressed without question. I know that's your heart, everybody else here as well. But I think that's really an important consideration that we focus on. What this bill does meets an absolute need. It's an urgency bill that meets an urgent need for diabetics. As a matter of fact, when I take a look at a bill like this, when I think of hearing Alec's story, which is a very potent, strong story, but he didn't just struggle with it 1 day or 2 days or 3 days. This is something that was on his mind for several weeks, right? And so had this sort of a bill been in place under that kind of an urgency and the system that we could have set up, I believe this would have been very helpful to Alec. On the other hand, as I said, this is a multifaceted situation. There are those who are in those few days emergency kind of a situation that can just happen to anybody through circumstances that just happen. That requires a different kind of an approach. And by the way, just to mention, I know pharmacies have been brought up here, but I know in refilling prescriptions, automatically on many of the refill messages that we hear when you call to a pharmacist, they will say if your prescription has no refills on it, or in a situation like that, they will call the physician on your behalf and work to help you get that information. So there is a spot in here, and I think it is a very valuable one for the knowledge and expertise of pharmacists, but I just thought it was really important to focus on the fact that this was an urgency type of bill, and I think even in Alec's situation, had this been in place, it would be very helpful. I just also wanted, Madam Chair, because I want to be sure to not forget, though, that the benefits of some of the previous legislation, what they actually did. I just did a little research on it that requires
Senator
health
Kiffmeyer?
plans to charge
Senator
patients no more
Kiffmeyer?
than, Madam
Senator
Chair, am I going beyond what you want to do right now?
You
I'm
would
sorry.
ask to jump
I
in
was just
line.
enthusiastic about information, and we'll save it.
Absolutely. I let you go because you were to Senator Marty's point. I think we've gotten a
Yes,
bit of field
and I
of
went
that.
beyond it.
So I'm going to return to Senator
Thank
Marty.
you,
so
Madam
can
Chair. My
finish your question.
last point is that I'll use Senator Kiffmeyer's terminology. This is a bill to deal with the urgency. Senator Wickland's is to deal with the emergency, and what we really need to do is fix the long term, which is the outrageous pricing in the first place, and that can wait till next session. But yeah, I have no problem with doing an urgency bill during the interim. I just think we should be dealing the emergency first, then the urgency in a triage sort of fashion. You deal with the emergency, then you deal with the urgency, and then you deal with the longer term. And I would, so Madam Chair, I will hope that this bill could be merged in with or taken in addition to the emergency bill. And I think both the bills should get heard and be dealt with this interim. And yeah, I don't disagree this will help. I'm not trying to do that. I'm saying I don't think this will help everybody in Alex Smith's position. I think the emergency bill would, but this would be a great addition as well. And so hearing both of the bills would make great sense.
Thank you.
Madam
Senator
Chair.
Franzen, actually, Senator Franzen's next on the list. We can add you. Senator Franzen.
All right.
Thank you, Madam Chair, and I think a lot of the concerns I have already been addressed. I just wanted to add a few other remarks and have a few questions for the author, and thank you, Senator Pratt, for working on this issue. I did not serve on any of these working groups, but like any other legislator here and in the legislature, I think all of us are concerned about our constituents who can't have access to affordable medications that are life-saving and pretty much that they're relied on for their lives. I think the issue is we're trying to fix something and we are trying to create programs and sometimes just make it even more complicated. I do commend the work. Again, I'm not in the weeds on the issue, but I am concerned about the shifting of costs, and I think Senator Marty talked about that. At the end of the day, we pay for it some way, somehow. And I'm concerned, I know we have a letter from Pharma, but I don't think they're here. I'm concerned about whether they've been talking to you personally about your bill and their perspective, because I'm concerned the cost shifting in pharma, frankly, of a manufacturer who might now have to find a way to pay for a sector of the demand for insulin and then shift that cost to those who can afford to pay, particularly in private plans, and then shifting more costs to our system, or that they're just shifting costs to other parts of their business. And the reason I'm concerned about it is because at the end of the day, we pay for it, and I don't want to hurt one subject, one particular group that's sick and relying on other drugs that manufacturer puts out versus another sector. So I think at the end of the day, we do have to figure out this cost. I know Colorado has this unique approach of capping the copays at $100. I'm not saying that's the best way of doing it, but to a certain extent, it simplifies the issue, because if we're talking about PBMs and all those cost shifts, it just, MNsure, who's going to pay for the admin costs there? Are we putting those costs? Are we making this sound simple, but in reality might be more complicated? So that's a certain reaction about the Colorado bill that makes me feel like maybe that's easier for people to follow, that I don't have to pay more than $100 a month on copays for my life-saving drugs. Especially when you think about it, I was looking up how much does it cost to pay for food in any given month, and it's anywhere from $250 to $550 is kind of the average around there in terms of what you would pay for food to live. This is the food people need and patients need to live, and we're asking them to pay upwards of thousands of dollars a month, more than what they would pay in food. Just seems like it's really off balance. So how can we work with these manufacturers to actually lower the cost? I'm not a big fan of mandates, but again, the Colorado approach I think is worth looking into, how they came up with that dollar amount and how it's signed into law. And I do want to commend the advocates, especially Ms. Nicole Smith-Holt, who you brought this issue to the forefront with your tragedy, but you've opened this conversation not just in this state, but other states and in, frankly, federally as well. So again, whether this approach is workable and sustainable, you also have a sunset, and I'm guessing because you want to revisit whether we should keep going with this program, but that sunset also makes me feel like we haven't thought about a long-term solution to the issue. So my question to you, have you met with manufacturers in terms of cost, and how are they able to afford this in the scheme of business? You're a business folks, so am I. Are they going to be able to take a write-off because it's considered charitable? Are they okay with paying the full cost of the program, and how to really make this sustainable? So again, to the issue of cost. And lastly, Madam Chair, I know I'm a little long-winded here, but lastly, I am concerned about the legality of the program as it's set up. Similar to the opioid bill, when we were trying to mandate someone pay for something, is this going to withstand the court of law? Because maybe the manufacturers will say, "We'll just sue. We're not going to comply with this. It's interfering with interstate commerce, and we're just not going to comply with it." And then we're stuck again trying to find a solution. So those things, the cost shifting, and have you talked to manufacturers, and then what are the legalities of your bill as it currently? Are you concerned about it actually standing on its own and being able to be enforced? Thank you.
Senator Pratt, and perhaps you want to talk about the more than $100,000 in excess rebates the state of Minnesota received on insulin products, as what impact that might have on cost shifting. So whenever you'd like to take Senator Fransen's questions.
Well, thank you, Madam Chair, and Senator Fransen, and that's a pretty big question. So let me just take it in chunks here, and maybe before I start, Senator Marty, I think what you're seeing. I don't mean to come out as angry, but I've worked very, very hard on this, and the idea of trying to prevent somebody from needing that emergency piece to me was a very appealing concept as we started working on this. Senator Fransen, I've talked to a lot of stakeholders through this process, including manufacturers, and it's through the manufacturers that we came up with the distribution channel, because what we're trying to do is leverage. So we already have co-pays being capped at $25 for many of the health plans. We have patient assistance programs that are already helping hundreds of Minnesotans, if not thousands of Minnesotans in the state. This is simply meant to be an addition to an expansion of the existing patient assistance programs, which is why we've got the distribution channel the way it is. I think from the letter from Pharma, I wouldn't anticipate any sort of legal pushback per se, but we would want to make sure that the program also isn't being abused, that we get patients who qualify for public health insurance subsidies onto one of our programs as quickly as possible, and even get them off this program so they can start not only covering their insulin needs, but covering all the other health needs that they may have. This isn't a bill to address pharmaceutical affordability across the board. This is a stopgap measure, while efforts that Senator Benson has already laid out that she's looking at move forward. And so this is a very targeted approach to a very, and to borrow Senator Kiffmeyer's words, which I really liked, and I'm going to continue to borrow Senator Kiffmeyer, this is an urgency bill to get forward and help to make sure that, I have a son that's going to be 25. We're going to start getting the notice that he's off our insurance pretty soon. Now, he doesn't have insulin needs, but he has other, like every other person, they have their own medical needs. And we want to make sure he's covered. But a parent should never have to bury their child.
Thank you. Senator Abler, and then Jensen Nelson.
Well, thank you, and thank you, Madam Chair, for the hearing today. It's on the autumnal equinox. I don't know if anybody knew that, but that's somehow poetic on this very important topic. And Senator Pratt, I want to thank you for taking on this really hard problem And after this, I don't know you'll ever want to come back to this committee. It's a really hard one. And I know we've talked a good deal, and I know you're personal passionate about this and what's in your heart on this. Having been the privilege to serve at these chairs for a while, some projects are bigger than any one person, and I think you've noticed that. And I think that a project like this, actually, there's different people that carry the ball for a while. Somehow those at the end of a football game, they keep passing the ball off to somebody and hope to get across the end zone in time to get the last point. And I think the pressure here that drives me, and I know drives a lot of us, isn't when we do a special session or when they get it sorted out, but when the next person dies. If one more person in Minnesota dies because the system was unable to come to an agreement on helping that person, we have failed. And there'll be plenty of blame to go around. I'm not going to point my finger at you. I'm going to that's what drives me on this thing. And so I could occupy till 1 o'clock with my questions, and I'm only going to ask you a couple. I want to ask you one question, if you don't mind, and then I have a couple of comments, and then I'll be done. Senator Benson mentioned early in the hearing, this is sort of a working hearing, and you're going to be listening, and so so I ask you fewer questions. From what you've heard so far, what changes would you be making in your bill just to kind of, that you've learned about today that you might alter? And if it's nothing, fine. If it's something, I'd like to know that. Thank you.
Senator Pratt.
Thank you, Madam Chair, and Senator Abler. Senator Abler, I think one of the things that has been solidified, and I talked about it early on, was that, no, this doesn't address every need out there. That there's still a need to have an emergency program. I'm still somewhat perplexed on why we wouldn't want to prevent some of those emergency needs before they occur, but there is a need, whether for whatever reason, to have that, to continue that conversation. And I know that you've been in our discussions, and I don't think I'm breaking confidence here, that's been a key concern of yours, and I want to continue that. It's been reinforced here. I think going back and looking at the comments from MMA, from Board of Nursing, from the Board of Health Practices, we need to continue to take those in. I need to meet, I will continue to try to schedule some time with MNsure to make sure that our timeline, we have a fiscal note requested that will help solidify the costs and the impacts that we'll have. Conversations with advocates after the meeting kind of inform me that we need to make sure that this meets the desire to build upon what's existing, not to replace what's existing, to be a safety net for those people that slip through the holes in the system. Senator Abler, I think in a nutshell, without talking until 1 o'clock, that's where we're at. I just have to acknowledge that I don't think I'd be sitting here today if not for the conversation we had on May 26th. And that was when you first reached out to me and said, this isn't sufficient, this isn't right, we have to move forward. Yes, I don't like being in front of this committee. Let me just say that straight out. It's nothing, I respect all of you, I like all of you, but I do want to, through my personal, for some of my personal reasons, and quite honestly, the oath that I took to represent not just my district, but the state of Minnesota, even though this affects many, many people in my district as well, I think it's important that we find a way to make sure, as I said a moment ago, that not another parent doesn't have to bury their child.
Thank you, Madam Chair.
Thank you. And just members, it's not my intention to go until 1 o'clock. I was hoping for a 2-hour hearing. I keep hearing 1 o'clock. It makes me a little nervous a bit. Senator Abler, if you could
Thank you.
wrap your point.
No, and I will appreciate that. And so I think I'll just make this as a comment, and I won't require more dialogue. But I do want to, this is really hard. And looking at those that Jesse was just tragic. So solution-wise, looking forward at this, I think that we're onto something here with expanding the programs the way you've done it. I think there is a gap on the emergency side. And I think we'll have to address that in some way. Maybe I'll come back to that. What I've been unable to figure out, talking to a whole bunch of people like you've been talking, is who needs this? Who is the group at risk? Looking at the different emergency programs from the manufacturers, looking at what we do and the charity side and all that. It seems like, in particular, it's the mid-20-something group, and then the accidental, my thing broke stuff. And so until we really know how many there are, it's hard to know what it's going to cost. But I would like people to point out that this program here is basically funded by the manufacturers. And I didn't realize, Senator Benson, that your bill was funded by manufacturers. I thought it was all state paid. So, and I actually ran this by them, and they're not all that happy about it. And so the reason I've been promoting a shared payment thing is to keep the lawsuit away. Because I am no defender of pharma. 40 years as a chiropractor. We're not exactly, having dinner all the time. And so, but at the end, if we put forward a plan that we all agree on 201 to nothing, and they sue us over it, that kid's going to die. I'm not okay with that. And so I think we need to sort that out. And if I could posit a way forward here, because at the end, the House and us and the governor have to agree on something. And it may well be that the House has got a strength in their emergency part. We have a strength in the more chronic part. And I'm really happy you got past day 91, because that was on my mind in our meetings. And I think there's somewhere to go with this. And that's all I got, Madam Chair. Thank you.
Thank you, Senator Jensen, and then Senator Nelson.
Thank you, Madam Chair, and thank you, Senator Pratt, for bringing this forward. Friday night, I received this message from a patient. I have a bad situation going on. I take Novolong insulin. Insurance wants me to switch to Humalog. Last time I did that, I went into DK and was hospitalized several days. I tried again, and I didn't respond again to Humalog. I run out Wednesday. We've been denied on appeals 3 times. Been advised I have to either pay $1,000 a week or present myself to the emergency room. Can't believe this is happening. It's an ongoing issue. The past is past. No more politicizing, at least for me. You've got a solid proposal here. There's some pieces in here that work really well that we hadn't thought of in our work group during the summer. But a lot of the ideas in the work group during the summer also make significant contribution, and Representative Howard and Senator Wickland's previous ideas and ongoing ideas could help us. After conferring with Steve Schondelmeyer, the MMA, multiple physicians, multiple pharmacists, I think what we should do is probably, I'm just going to go with a fix, because I want to talk about the nuts and bolts of this bill to see if I can help make it work. First off, the patient applying through MNsure. MNsure has infrastructure, software platform that can help, and Senator Benson and Senator Pratt have unearthed that and talked about that, and that would allow us to move forward more quickly. I think the public is right now misunderstanding that you do not have to have an insurance plan under MNsure in order to qualify for support. If this provides the uninsured, the underinsured, this provides support for if you're under 400% of the federal poverty line. So I think we just need to understand that MNsure's role will be in the application process. I do think that whatever we do, Senator Pratt, I would beseech you, please don't lose sight of the emergency piece. We need to incorporate that into this bill. There is not an emergency and then this. We should, when we're done at this should have an emergency component. I think if we would switch back and sort of meld what Representative Howard's bill is saying and your bill is saying, I like the idea that you reinsert the physician's office back into the equation, because it may well be that something has changed. And I think that the MMA and Schondelmeyer and other people have made a good point that right now that would be a cumbersome thing to do, is to have the the product shipped from the manufacturer to the physician's office. What we may want to do is use some of the language Representative Howard has done, where we go ahead and we ship it to the pharmacy because they are equipped to receive it, and they are open more hours. Certainly on this Friday night call I got, our office wouldn't be open again until Monday morning. But I think if we just look at some of the details of your plan, the patient would apply to this date either through the MNsure page or through the doctor pharmacy. I think that works. But I think what we could do is, instead of saying the form has to be, if you will, signed off by the doctor sends it in. The doctor's offices oftentimes, especially with the cumbersome EHRs that we have, they'll lose it for 2-3 days. Blue Cross requires us to respond to patients' phone calls sometimes within 3 or 4 days, business days. That's the baseline, that's the safety net. That wouldn't be good enough here. We'd be losing too much valuable time. So I think it may well be that to allow the doctor could sign off. So the patient would go to the pharmacist, as I think Representative Howard's bill might say, and the pharmacist would then contact the physician, because that contact that happens quickly. And typically pharmacists call me, I'm back within an hour or two. So the pharmacist will say, I've got a patient here, can't afford it. Do you want to tweak this? Do you want to see the patient today or tomorrow? Or can you sign off on this? Because we've got a prescription from 3 months ago, 12 months ago, whatever. And so the physician would get a chance to be reinserted into the equation, if you will, but would sign off potentially, and the pharmacist would help the patient complete the form, mail it off, and then the product would go back to the pharmacist. It would be right there, and the pharmacist open 7 days a week. That would grease it, and we would save some time. I think the pharmacist, we could also say that if the pharmacist would be allowed to provide an emergency 10-day supply to be replaced when the pharmacy receives the product from the pharmaceutical manufacturer, if we could work through that, then all of a sudden we've cut out some of that lag time, and we still have the physician being reinserted. So I think a couple of the ideas that really come out of your bill that I really appreciate is working through MNsure. Clearly, DHS has plenty of issues and plenty of things to solve on their table. MNsure can help us with that attestation process, and that can go quickly. But then I think to have the pharmacy be in the driver's seat in terms of submitting the form, receiving the product, getting the product in the patient's hands. Then we get rid of some of that language about physicians dispensing, because most physicians don't dispense. Some do, but most don't. And it's still, if we continue to hold on to some of that, I think very important idea, reinsert the physician into this so that we would say, I mean, if it were me, I would say, I said to this guy on Friday, I said, listen, I said, come in Monday morning. You know, I've got a couple of pens that I can get from my sample supply. And I said, let me contact your insurance company. And, you know, I think physicians most of the time would do this. But if they don't, if it's a big system or they don't even know, or maybe they're out of town, these things would fall through the cracks. I think if we have the pharmacy play the lead role, I do think that's better. After hearing what I heard from Schondelmeyer, the MMA, and Ms. Munson, I think we should definitely beseech you to work hard with Representative Howard over the next 5 days, because I think we're close. And thanks so much to you and Senator Benson for having a hearing and getting this moving. There's no reason why we can't get this done. There really isn't. Thank you.
Senator Nelson.
Thank you, Madam Chair. And I, too, am thankful for this hearing today. This is an issue that's important to every one of us. I particularly think about the mothers who are here today. And so it's important that we spend the necessary time on this issue. But I just want to add a couple comments to the noteworthy comments that have already been made. On the one hand, I'm excited that we're having this hearing today. But as I sat here for the last 2 hours and we listened to the comments, I also was a little concerned that there still seems to be a schism. There must not be. We can walk and chew gum. We should be able to have an urgency bill and an emergency bill. We expect people to have, we want people to have great health care, and yet there are emergency rooms. The same thing with insulin. We need to have the great urgency bill, which is everyone needs that continuity of care, but we also need to have the emergency consideration as well. And I do hope that's something that the conversations that have already started will continue on that path. And then I want to applaud those who have stepped up recently and have done the right thing. Now, maybe they were forced to by the good legislation that Senator Benson brought, that we passed, requiring that that insurance companies cannot make money off of insulin. But regardless, I'm glad to see that UCare, Medica, Health Partners, Blue Cross, well before today, all stepped up and put a cap on out-of-pocket expenses for insulin, I think $25, or for free. I think that's a great thing. And I was kind of scratching my mind thinking, well, we don't have very many health insurers in our state, so who isn't at the table? Who hasn't stepped forward? To Senator Abler's point, who is it that where's the gap that we're trying to fill? Who is not able to get those insulin prescriptions at those self-imposed caps? $25 a month or for free. And quite frankly, there is one insurer that's missing, and I'm going to call them out because I think they should also be at the table, and that's Preferred One. Now, Preferred One, interestingly enough, is our state health insurance programs. And so I'm hopeful that Preferred One and our CGIP programs will also get on board and limit those out-of-pocket expenses to $25. Usually we say as leaders we should lead by example. Well, now we're not even following an example, but I'm hoping that's something that will come. And it also seems, as I was trying to narrow down who is it that's not being served and not able to get emergency life-saving insulin, and it also seems that it is the self-insured, those ERISA plans, and that's a little bit harder for the state to put pressure on, but I believe in public pressure, and I believe that I'd like to see those self-insured ERISA plans also have that out-of-pocket expense cap as well. But then the folks that is the non-insured, those who don't have insurance, how can they participate and how can we make sure that they get insulin at a reasonable price, whether it be as an urgency, a continuity of care, or in the case of an emergency. And I would look for us to do that. There's a couple things that I would point out as we move forward here, and I hope we will, and we will get to an urgency solution and an emergency solution. One is something we have not, or at least I have not heard of in this hearing. I know I brought it up on the Senate floor when we were debating some insulin amendments earlier, and that has to do with any unintended consequences that would actually raise the cost of insulin. And we talk about needing to hold down the cost of insulin, which has really perpetuated much of the problems that we're seeing here, is those skyrocketing costs. I hope everybody has seen this chart. But one of the issues is if we're going to see a cost reduction, we also need to be able to see generics and biologics. And at this point, the feds are not certain. It says that the feds have said that they will have a biopathway for insulin in March of 2020. Now, some companies are trying to beat that and get through the generic pathway. Either way, what we do here today, we need to make sure that we are not inadvertently increasing the cost of either biologics or generics for insulin. That's part of the problem right now. We don't have that generic or the biologic. So I'd like to make sure that any legislation going forward addresses that concern. Also, I'm a bit concerned about, well, I love inserting the doctor into the patient-doctor relationship, and I talk about that often. As Dr. Jensen mentioned, I think having the second trip back to the physician to get the emergency or the urgency insulin, I think is problematic. And I'm thinking particularly about Ms. Stanley, who already is having a hard time getting in to see her endocrinologist. We talk about in healthcare making sure that everyone is working up to the top of their licensure. And I'm concerned that perhaps the legislation, the draft that's before us today, should be tweaked so that, yes, we have the doctors prescribing, but then fulfilling those prescriptions, we need to have that pharmacy connected there. So I would look for that. And the licensing boards also brought up great points as well, and I saw you taking good notes on that as well. So I'm hoping that those will be incorporated. So again, the work has started, and we have more to do. I hope that all the good points that were brought forward today, both in testimony and at the table here, will be taken into account. And at the end of the day, which I hope is very soon, we will be getting an emergency insulin bill and an urgency insulin bill. I would see it as being one bill in the same.
Madam Chair, to Senator Nelson's comment,
Senator Jensen, briefly.
I think it's important to realize that $14 billion of samples on insulin are shipped out by the three main manufacturers. And what Senator Pratt has been able to do is get pharma to look at that $14 billion that they're already doing. And on the premise of a lot of the patient assistance programs, he's actually moving that over into a program that we write, that you write, and it works. So this will not have some taxation effect downstream on anybody else who's paying their regular price for insulin. There's already $14 billion of insulin samples given out in the last decade. So we're not running into that as a problem. Thank you.
And Madam Chair, I did not think that was a problem, but thank you for clarifying.
And next on the list, Senator Kiffmeyer, then Senator Wickland, and I'm going to close the list, members, unless I see your hand right now. Okay, Senator Kiffmeyer briefly, and then Senator Wickland.
Thank you, Madam Chair. I really appreciate all the discussion we've had today, and I think Senator Jensen's comments in particular, his knowledge and experience with the depth of the system gives us great value. And I know that Senator Pratt also taking notes and carefully listening to all those suggestions so that we use the work of today to come out with what is a good bill and making it even better, and I appreciate that. I do think, though, that the approach of avoiding emergencies whenever we can is by far better. It is difficult, it is hard to be in an emergency situation, especially with the disease of diabetes. So this one is one of those that really calls for longer-term stability and consistency, and then also making sure that we try and do everything we can to keep them away from an emergency situation, and yet for those few times that you may have that. But I do think that I did a little more research on the work that we did in last session, in particular Senator Benson's bill that said health plans cannot charge a patient more than the net cost. That means they cannot profit, but it's the net cost. And according to that, again, some of the money in the system is being redirected directly to patients, was such a comment that I made on that subject. Get this money directly to the patients so they benefit rather than floating through the health insurance or the PBMs. And that's what your bill did, Senator Benson. And the statements are, by doing that alone, the cost of, say, a product like insulin could be being reduced by about 70%. That's a big deal. That's a great effect and a great benefit, and it should not go unnoticed that that is part of a great process here. But in this particular bill, I think, Senator Pratt, you really have a really good, and I think with some of these suggestions, some of the other things, adding on that few situations where you might have that emergency kind of a thing, I think we really have the potential here for a great step forward in some solution for folks who are in this situation. So thank you.
Thank you. Senator Kiffmeyer, Senator Wickland.
Thank you, Madam Chair. First, I just comment. It was brought up that perhaps our state programs don't have a diabetes-focused program, and they do. CGIP actually has a really comprehensive diabetes management program that I think it's either $0 or $25, or very low copay. It includes some other features as well, but I just wanted to point out that that is something that our state offers, and I wish that that was available across the board for all people. And so, in conclusion to all of the conversation, I guess it sounds like we have a lot of good ideas, and we have a lot of agreement on some of the desired outcomes of this, that we have programs that will assist people in various situations, either emergency situations or an ongoing situation. And I'm wondering, Senator Pratt, would you be willing to work with our bipartisan, bicameral group to continue discussion and refining both of the concepts and having either a single proposal or both bills fully fleshed out so that people can really analyze whether we're meeting all of the needs?
Senator Pratt.
Thank you, Madam Chair. I didn't want to step on the line again. Thank you, Senator Wickland. You know, as I've said, part of the problem with this is it's been too political. We need to start talking to each other. You know, I'm happy to have these conversations, both bipartisan, on a bipartisan basis and a bicameral basis. And so I think short answer is yes. Yes, I am. But we can't forget the other stakeholders that are a part of this, which now, quite honestly, includes Senator Benson and a number of all of you as we've gone through this. Like I said, I met with Representative Howard, and we kind of agreed that we needed another plan to go out. Now, I don't know what the House is going to propose later this week. My guess is they're going to take some of the characteristics of our bill, and that might make those discussions easier. I hope they do. But yeah, I mean, yeah, if I were to close up this discussion, I would say that this is a plan that should garner bipartisan support. And I've acknowledged that there are still some pieces that we need to work out, including that emergency piece. Now, if the wrap on this proposal is, well, it's not emergency, and in some cases that's what I've heard today, then I'm very, very pessimistic on our ability to get something done. If we can get the governor to engage, if we can get the House to engage, if we can, you know, if the governor doesn't, if the governor's serious about doing this, I think we can get something done.
Madam Chair.
Senator Wickland.
I think that it's clear to me that people are very interested in seeing the different needs of different people met, and I don't think that, I didn't indicate that it was a wrap on your proposal, but it does not include that aspect, and so we need to find a way to have the discussion so that the full proposal can include all aspects and also flesh out your proposal further so that the full process is understood and we make sure that all the stakeholders have input on that. So I hope that we can continue the bipartisan discussions.
Thank you. And Senator Pratt, I do have a little concern about a perverse incentive that if somebody can get $25 insulin and they come over here, they can get free insulin. So I think there are some eligibility requirements that we might need to work out, but that will be part of the workflow process as we engage with MNsure going forward. The things that I'm grateful for, that your bill pushes people to a place where they can see if they're eligible for a public program. Half of our uninsured approximately are eligible for a public program. We want to make sure that if they need something, they're getting it and it's done appropriately through MNsure. If they're eligible for help with a qualified health plan, your bill covers the gap till the next enrollment period. I think that's important that we purposefully cover that gap. You're using existing infrastructure. The MNsure eligibility portal will be important for public programs and QHPs, but we can also direct people to manufacturer support. The Board of Pharmacy accumulates that information. The pharmaceutical companies have their MAP program now, and we can direct them to that sort of support. So as we dig into this, and I would challenge all of you, our state gets rebates on insulin, a lot of them. We haven't even touched that. There are other entities who have advantaged rebate positions. If we want to talk about cost shifting, understanding who gets those advantage rebates and why they're not available to the general public is a significant conversation. And why would somebody get more in rebate than they paid for in product? So I think some of this needs to come out into sunlight, which is why I think the transparency bill and the PBM bill were just nods that this is going to happen. My eminent frustration is, why do we have all these perverse incentives for rebates in the first place and not just be in the market with a straightforward pricing model? I've said that from the beginning, which is why I wanted to take a much broader approach to how we make pricing more transparent and accessible to the consumers of the products. I applaud your bill in that you honor the importance of contact with primary care, because people with complex medical illnesses need more than just the drug. And so by nudging people to their primary care physician shows a concern about the wholeness of their care. And so I just wanted to say that I'm grateful you brought something that was robust and challenging. I hear a lot of unhappy people. I'm sorry. I think that you have a really good start, and as we go through a disciplined, robust process for moving this bill, we're going to find a way to care for those who are in a gap and to build a solid structure underneath for those who need support. And so with that, Senator Pratt, your closing comments.
Thank you, committee. Again, the goal here was to take some of the politics out of this issue and really address it in a way that is proactive, and yet compassionate. And so thank you. Thank you, Madam Chair, for your help on this, Dr. Jensen, Dr. Abler, along with others. To all the people that have kind of informed me along this journey, I've learned so much, and I continue to find out I have so much more to learn as we go through this. So, Madam Chair, I'm looking forward to continuing to, as you term it, sandblast this thing until it's smooth and we're ready to go.
And with that, members, we are adjourned. Thank you for your attendance.